Hello and welcome. My name is Stenner Helbling. I'm a medical oncologist. We are here at the ASCO update in Zurich 2013. Next to me stands Dr. Frank Stenner. He is a genito-urinary cancer specialist from the University Hospital in Basel, also a medical oncologist. Now, Frank, please tell me what were the relevant practice-changing studies at ASCO this year?
So first I would like to explain a study of germ cell tumors. Here we have seen progress made by a French-led group in the field of poor risk germ cell tumors. Patients that have a poor or dismal prognosis, only 48% can be rescued or healed with the chemotherapy. And in this situation, this group has undertaken a trial called the GTOC13 trial, where they have examined whether a more dose-dense chemotherapy is a benefit for patients who do not decline with a tumor marker in adequate time.
Okay, so after 21 days they were not falling adequately with the tumor markers, and then they were dose intensified. They got more than just the 4 BEPs.
That's right, and they were randomized. So the favorable group received 4 BEP as the standard therapy, and in the unfavorable group, the patients were randomized one by one to a dose-dense chemotherapy comparing to the standard BEP chemotherapy.
Okay, and what was the main finding there? Was it better to give them more chemotherapy?
More chemotherapy resulted in a better progression-free survival at 3 years, and that was significant. But the overall survival between these two groups was not different. And from this perspective, one must say we have a signal that dose-dense may be important for these patients, but we cannot change our practice as of today in this regard. But what we still can take from this study is that the early marker decline is a very important practice-changing thing that we should do with these young and unfavorable patients, because with this we can direct them to more intense chemotherapy, or we can be confident that the standard chemotherapy, if they decline adequately, will heal these patients.
Okay, so after 21 days, if the markers do not fall adequately, these are bad risk patients in that sense. They stated at the end, if they give them intensified chemotherapy, they have a better PFS, and that's a new standard. But you now say it's not a new standard because it's a complicated regimen, it's toxic, and we have other options as well. So you would rather just filter them out, those bad risk patients, and then what would you do then? You would give another BEP and then perhaps do high dose, or what's your option?
We can start, as this group did, with 1 BEP, and then after this, I'm afraid we have to do something more than BEP for those who do not decline adequately. And this scheme is really with 6 different chemotherapy agents and a very complicated scheme, hard to adapt immediately. I think we will have to find a compromise within the germ cell tumor group what to do. Until then, we could probably do TIP chemotherapy that we are very familiar with, and Darren Feldman and colleagues showed that for a very similar group they had a comparable outcome, but it wasn't, of course, a phase 3 comparative study. So more mature data here is really wanted.
Okay, so you conclude that this trial showed that those patients who do not fall adequately are bad risk, they need another treatment, but with that regimen it might be difficult to implement in practice because it's complicated, toxic, and not so easy to do.
Absolutely. And those patients who receive standard chemotherapy, because we cannot manage this complicated scheme, would need close follow-up. So in case of relapse, they could be early candidates for high-dose chemotherapy, for example.
Okay. Well, thank you very much. Were there other trials in testicular cancer which were of importance? Think about something about surveillance?
Yeah, right. In early seminoma, so stage 1 seminoma, where we, as of today, recommend either active surveillance or 1 cycle of adjuvant chemotherapy. The Danish study group has shown data that probably too many patients receive chemotherapy today, and that more patients could be managed with active surveillance.
So this single cycle carboplatin is not really necessary for everybody. Or
Not for everybody. They also show risk factors that we already know of. For example, tumor size larger than 4 centimeters or lymphovascular invasion positive. And if you have 2 of these factors, your risk of relapse is above 37%. So, I mean, this is something we have to discuss with our patients. If they feel uncomfortable, then they should still receive chemotherapy. But even those patients could all be rescued in the end. So 99.5% was the overall survival after long follow-up and observation periods. So it is an individual decision that has to be shared between the doctor, the physician, and his patient.
okay, seminoma stage 1 surveillance is safe even if you have a high risk of relapse, but not for every patient it is comfortable to have a third risk of relapse. So you have to psychologically also adapt to that idea. Although you will be cured finally, or most likely cured, it's difficult to, perhaps for some, to adapt to that idea, I think.
That's true. But what we learned from these data as well is that patients who do relapse usually relapse not with the highest stage of seminoma. Most of them will relapse with a stage 2A or B stage, and they would be candidates for radiotherapy at this stage. So that is something that we would have to inform our patients as well about. So if you relapse, you are most likely to receive radiotherapy in this situation.
Okay, so there's a trend towards more surveillance in these stage 1 seminoma patients because of this data, because they're safe. That's the main message.
That's the message, right.
Okay. Other interesting data from the...
Yes. Again, in stage 1, non-seminomatous germ cell tumors, the Swedish Nordic group has shown that patients who have had 1 cycle of chemotherapy in adjuvant intent BEP was curing most of these patients, or was sufficient, and the guidelines are still in between 1 or 2 cycles. And I think with this new data and being sufficient for 96.6% of all patients, we are now faced with a new standard of 1 BEP adjuvant therapy for patients with lymphovascular invasion. For those who do not have that risk factor, they can well be managed without chemotherapy, or if they feel uncomfortable, of course, they can also have 1 cycle of BEP.
Okay, so that's really a new standard. 1 cycle is enough instead of 2 cycles in non-seminomatosis.
That would be practice changing for many, and I hope spare a lot of young people toxicity and long-term risks for secondary cancer and other problems associated with this chemotherapy.
Okay, great. So there was quite some change regarding testicular cancer. Was there anything new regarding renal cell cancer?
Not actually practice changing. We had the Record 3 study presented by Bob Motzer, and here we saw that the mode of action TKI first followed by mTOR inhibition that we are used to has withstood a randomized trial setting, so we should stick to this because it was clearly inferior if you started with the mTOR inhibitor first. Many experts have reasoned there may be a place for mTOR inhibition for a certain subgroup of patients, especially those with non-clear cell renal cell carcinoma, or those that are poor risk patients, but there was no signal from this trial that the mTOR inhibitor would be better there. It was actually the other way around, and to me and for my practice, it may change the perception of a poor risk patient, whether I would always start this patient with an mTOR inhibitor, in this case temsirolimus, or if I do not, one or the other patient start with a sunitinib treatment that has now shown to be advantages over mTOR inhibition for this subgroup of patients.
Okay, so I mean that's also in a way practice changing, because some of us have still treated high-risk patients with temsirolimus in that sense, or with mTOR inhibition. Now we see that if you take the TKI sunitinib, it's even a little bit better, also in the high-risk group. So there's not much reason to take any mTOR inhibitor at the beginning. That's correct. So that's what your conclusion.
Now my conclusion is the phase 3 data from Utz and colleagues still stands. Temsirolimus was a good first-line treatment for poor-risk patients, but this poor risk has to be really defined as it was in the study, and that is not just Memorial Sloan Kettering criteria. There are other factors that go into that, like poor performance status and thrombocytosis. And if you do not have this, and if you regard your patient as fit for TKI, in this case, you should really consider TKI in first line, because you have a better overall response rate, and that may account for the patient in the end.
Okay, so thank you very much. Other TKIs, I mean, we have not only sunitinib. Do you think it has to be sunitinib first line, or do you think there's also others you can use?
Yeah, for poor risk patients, there is no data on the others, or not enough data on the others for daily practice. We use, of course, pazopanib and sunitinib both as TKIs in first line, and the tolerability profile of pazopanib is better. We know that from 2 studies now, so there is an alternative.
Okay, thank you very much. I think these were the practice-changing data, correct?
I would say so. Prostate, I must say, we didn't have great data this year. If you are interested in this, maybe the study from England, the Trapezi trial, could be interesting, but it's not practice changing, because most of these things are already implemented in our daily practice.
Okay, Frank, thank you very much for this interesting interview. Bye-bye.
Bye-bye.